Last year, we published a big paper that showed that 29% of these have bacterial biofilm.
They form biofilms, and pathogens make their way there to hide from the immune system because it's a safe haven.
Your body makes a capsule around it. Doesn't matter if it's a knee, a hip, a breast, a dental, cardiac, neurologic, whatever. Instead of it just being a T cell response, now they're finding more B cell and plasma cell response. So that's more of like you would see an organ rejection. So if someone complains of like brain fog and fatigue and joint pain and muscle pain, and they have gut problems and shortness of breath and palpitations, like I did their explant procedure and found out they had a hidden infection. And so that really bothered me. If you were just to unzip the old incision and pull the implant out and leave all the capsule in, that material would still be stuck to inside the body. And it was 2.2 million annually who get implants around the world.
Here with the board-certified plastic surgeon today, answering all your questions about BII. Do you even know what that is? Breast implant illness. All right, how to take them out correctly? What about putting them in? What about augmentation? What about plastic surgery in general, especially non-invasive procedures that we're going to talk about? I'm here also with my lovely wife, who's going to bring a lot of questions of her own, but Dr. Rob Whitfield, the expert, the man. I was on your podcast and had a lot of fun talking about these topics. And I said, man, we got to have you on ours. All right. A lot of controversy we're going to talk about here. When you're talking about BII, breast implant illness,
Sure.
You probably are kind of hated in your little community of plastic surgeons, I'm guessing, because, I know how that goes. But, let me just back up and say, how did you end up a plastic surgeon? Give a little background of yourself before we dive into these amazing topics.
Sure. Well, thanks for having me. It was a pleasure to have you on my show. So I'm very happy to be here today. So plastics for me was not my first interest in surgery. I wanted to do pediatric heart surgery. And
you're a microsurgeon, right?
Yeah. And afterwards, you start training and then you see kind of the different aspects of surgery. And then I spent a year in the laboratory and did microsurgery in the laboratory. And that's really where I found my passion for doing microsurgery. So I then went into plastics with my direction towards just oncology reconstruction. So I did a lot of head and neck cancer reconstruction, sarcoma reconstruction, and then the most prevalent cancer, breast cancer reconstruction.
Mm-hmm.
And ultimately, it was a breast cancer patient who was not actually mine, but came to have a consultation who wanted to go flat. So they wanted to have their implant-based reconstruction removed that they had placed several years prior. And I did their explant procedure and found out they had a hidden infection.
Mm-hmm.
And so that really bothered me. My sister, y'all don't know this, she passed away early in 24 from breast cancer. She had had breast cancer since I was in med school and dealt on and off with the complications, and she had a recurrence and ultimately passed away. And had someone missed an infection on her, I would have obviously been very upset. And I went back through all the notes and everything and the scans, and there was really no indicator of this. So when folks are, from the practitioner side, from the doc side, trying to figure out, basically from the provider side, I often think of how difficult this would be to understand, right? So if I miss somebody's infection and I have 20 plus years of surgical experience, this is what I do for a living, how easy is it going to be for somebody in your position or another provider's position or a specialist position to figure out what's going on? So if someone complains of like brain fog and fatigue and joint pain and muscle pain, and they have gut problems and UTIs and bacterial vaginosis and shortness of breath and palpitations, like how are you supposed to understand all those things really lead back to, immune dysregulation?
Mm-hmm.
And then like why?
Right.
Now, I always say, like, if everybody showed up with a red swollen breast, this wouldn't be that complicated.
It would be cause and effect. That would be simple. Right. Yeah.
So this is more of your body's immune system in the prodromal phase.
Mm-hmm.
Like, it's not infected to the point where you can see it, but your immune system is constantly being signaled and it's ramped up.
And by the way, this is what we deal with even in dentistry, meaning that people have cavitations. These are infections in the jaw where they typically get a tooth removed, like a wisdom tooth. And infections in there for years.
Yeah.
No one typically has a problem right away, and typically you don't have pain. Okay, but yet it's affecting the immune system, only to be discovered, hopefully, 20 years down the road. And, now they're making these connections, how it's affected the immune system. So if you had pain, oh my gosh, I have this pain in my jaw. Oh, we go look in, there's infection, then it becomes something. But when there's no pain and it's years later, there's no.
And those findings are not, so I've interviewed, just like you have, a lot of biologic dentists, and they say those findings are not always so obvious. So it's not
right.
You cut and dry that, oh yeah, there it is.
Yeah, exactly.
And people ask me, well, why can't I see this in an MRI or a mammogram or
well, and it's the same
scan?
problem because you can't see them on plain films, these cavitations, right? And then even when they use a cone beam, which is a 3D scan, they still miss them, right? So same problem with the breast, right? I mean, same thing. Okay, so breast implant illness is now becoming a thing.
That is a little comical because I testified at the FDA hearings in 2019.
I know you did. Yeah.
It's like this, it should be better understood at this point. And I think the problem is, just like I said, right? So, and I tell it this way, Dr. Pompa, I find this interesting. The first kidney transplant was done in 1954 by Dr. Murray, who's a plastic surgeon. He did it on a monozygotic, so a genetically identical twin. So as well as I do, that's always going to work provided you hook the parts up, right? The plumbing has to be hooked up correctly.
You're right. Exactly.
The blood vessels and the ureter, which drains the urine from the kidney to the bladder. But what it showed was, not just that it could be done, but that was tolerance. So you put something from one person to another person. The only reason it worked is because the genetic code is identical.
That's silly.
So then the next step is, and this is where the rub is a non-identical twin. So every step after that requires a level of immunosuppression. Doesn't matter what it is. So fast forward to now, and last year we published a big paper that showed that 29% of these have bacterial biofilm. So everybody listening, the first biofilm was, we were talking about teeth, it was plaque. That's what plaque is. It's bacterial biofilm. So there's two bacteria that readily form biofilm that are found on breast implants. This has been known for a long time. Cutibacterium acnes, which used to be called proprion bacteria, and then Staph epidermidis. So, okay, how does that shit get on implants? Then people ask me, oh, is it happening in the operating rooms? Like, no. Like, it is supremely hard to have that happen in an operating room. The staff can contaminate it on giving it to a surgeon. The surgeon can contaminate it upon entry into the patient. Those are all really, really low. That's almost less. It's 0.00001% probably. What happens is you get a cut, you get a cold, you get a GI infection, you get a UTI. That bacteria gets in your bloodstream, and then that sticks to a device because the device is not yours.
Just like any implant, they're finding this out with knee, hips, right? They form biofilms and pathogens make their way there to hide from the immune system because it's a safe haven. They're trying to survive, hide from immunity. And they're going, oh, wow, we didn't realize that hernia meshes will form biofilms, and all of a sudden pathogens are there building up over years, driving low-grade systemic inflammation, causing brain fog, anxiety, fatigue, et cetera, No different with breasts. Your immune system knows that they're there. Bacteria find their way there, low grade. And if they look at them, they're fine. But are they?
So is it safe to say every implant is eventually going to be a problem?
Well, they all form, your body makes a capsule around it. Doesn't matter if it's a knee, a hip, a breast, a dental, a cardiac, neurologic, whatever. It doesn't really matter what it is. As it relates to the breast implants, because I've spent the most time and effort trying to understand, the scar capsule around those, I can just speak to that. There's new literature that supports it's acting like it's rejecting an organ. So the reason I brought up the kidney transplant was the genetically identical twin can't be rejected, right? Whether it's the skin, which is the most antigenic. And Dr. Murray did the experiment by putting the skin from the one twin onto the other twin the week prior to the transplant to see what would happen. And then it was fine. Now, fortunately, it didn't get infected. So they oh, okay, we can do this. And then they did it. So because they didn't need any drug to stop the immune response.
Mm-hmm.
But now what they're finding, instead of it being like a foreign body reaction from say like a splinter stuck in your finger where you form a giant cell, which is the standard foreign body reaction, histiocytes, giant cells, all those things on the microscope. Now they look at RNA analysis, and basically we use a big word, transcriptome. So you're seeing these genes express different things at these capsules now. And if transplantation started in 1954, but the molecular analysis hasn't caught up till now of gene expression, that's why you don't have the explanation, if that makes sense.
Yeah.
Like you can put things in and try to figure out the response, but if you at the molecular level are just now beginning to understand what's going on from the genes that are being expressed, so things like matrix, metalloproteinases, there's a different cytokines being expressed. And instead of it just being a T cell response, now they're finding more B cell and plasma cell responses. So that's more of like you would see an organ rejection.
Yeah, I was just going to say, I mean, to someone watching this, what does that mean? Like they don't understand that language, right? So like, what is that expression as far as?
So instead of seeing what you would see around a splinter, which is mostly just a reaction your body makes, like forms a little shell around it.
Yeah, exactly. Mm-hmm.
This is actually just like I put a cadaver kidney in you, and your body is like, ooh, that is not mine.
Okay.
I'm going to create antibodies.
So it's walling it off.
Right.
And we're going to reject it like reject an organ.
Right.
So that's ramping up both your B cell reaction and your antibody. You're making antibodies against it.
That's when it would be BII, breast implant illness, meaning they're going to express symptoms that they don't or not necessarily associate with their breast implants.
So this is why people don't like me, because there's this controversy. I'm sure you've heard about capsulectomy. Should we take the capsule out?
Yeah, I want to talk about that because
this is why I take the capsule out.
I want to get there, but before we do, because a lot of people are getting their breast implant. I wouldn't say a lot, more and more.
Yeah,
are getting their breast implants out. And they're not taking the capsule out. Right. And then we have more complications potentially. So we're going to get
Is that like the hole in the jaw then, where if you don't clean it out properly,
yes, that's a good analogy, actually. Yeah. Did you see this? This is in a prestigious journal. It's breast implant illness, symptoms, outcomes, and explanation, and potential etiologies, a systemic review and meta-analysis. And they're talking about the prevalence of psychiatric illness, autoimmune conditions, fibromyalgia was 16, 20%, 12% respectively. I mean, for this to hit, for that to hit a major surgical, this is a plastic surgery journal, isn't it? And a prestigious one, I think. You know them better than I.
It's the International Society.
Okay, yeah. I mean, for it to hit that, I mean, I'm surprised they allowed it. How did this go over in the community? This was recent. This was just, I mean, like 2 months ago.
I have it on my tablet. I was looking at it.
So, I mean, but this is like saying this exists. This is a problem.
Yeah, the recognition is not as high as it should be, but then it's, instead of trying to understand it, like we were discussing at the level it needs to be understood, like I don't like problems that don't have solutions.
Yeah, me either.
So if you're going to say something.
Seems like my life's loaded with those right now.
You shouldn't talk out of your ass. You should try to figure it out.
That's right.
And when I was president of the Research Foundation, I said I would fund research to help provide answers to this. So they started. If you look from 2019 to now, the uptick in papers and publications about it, huge improvement. But also some of the head in your sand stuff is similar, right? Ignoring it. It's not a thing. There's people like they're making like little videos about me. Why is he saying this? Why is he talking about capsulectomy? And the paper I'm quoting is in a society's journal, which I can't believe they had actually put it in there because it directly refutes what they say, which is don't do a capsulectomy. When in fact, they're actually showing you why you should be doing it.
Why are they saying don't take the capsule out when the capsule is typically where a lot of the infections are, a lot of the pathology is found.
I think it serves them, right? So from a membership standpoint, if they want their members to do the safest thing, which is not do a capsulectomy because it's not going to potentially harm a patient.
Okay. Okay. So there maybe, explain to some people, what is the capsule? There's probably confusion.
Yeah. So the scar tissue forms around the device, just like if you had a baseball and you implant it in somebody, it would be walled off immediately.
Okay.
Within 24 hours, your body would react and
Immune
start
system.
flooding cells to it.
That's the capsule.
Laying down collagen. So it's a big collagen sac.
Mm-hmm.
And so the first implants were placed in 1962 in Houston, Texas by Cronin and Giroux in this country via Dow Corning as the manufacturer. So those were silicone elastomer shell implants. And if you look in the literature between the 60s and 70s, I tried to look at all the different papers written about those implants.
Mm-hmm.
And specifically about capsules and capsular contracture, because contracture, the hardening, the firmness, the distortion, the pain caused by that is one of the most devastating complications you can have whether you're a cancer patient or a cosmetic patient. And there's never been like an answer as to why is this happening? Who's the most predisposed to it? What can we do about it? What are the most, what's the guidance, right? We just want to know how to help patients. So when I reviewed the literature, I was like, okay. All implants started by being placed above the muscle behind the breast.
Yeah.
And then by 1975, there was a system called the Baker classification system to rate a capsular contracture, 1 through 4. 1 basically normal, 4 worst, painful, distorted, hard. Not a very elaborate system, very subjective. But as an examiner, you could help figure it out and communicate with me. Maybe you're the primary, you saw the patient, say, oh, I got to call Rob. Like, this is bad. He hasn't seen her in a while or whatever. Call me up. Hey, she has this hard, distorted, painful breast, and see her. And okay, then what do we do? Right now we've communicated about this, but then what's the guidance? There really wasn't any. Back then, it was pretty barbaric. They would smash the lady's breast and try to do what's called a closed capsulotomy, or break the capsule apart. So that would not be very nice. I would never do that or recommend that be done to anybody. So that was a practice. And then they turned to what's called open capsulotomy, open it up, take a portion out. Of course, that nothing really happened out of that other than recurrence. And so nobody really understood what was going on. They knew that bleeding was bad and infections were bad, so they tried to take steps to avoid that. Obviously, those are just technical issues, but they still didn't know why people were forming the capsular contracture outside of those parameters. So what did they do? Well, they put the implant behind the muscle, and then magically the rate drops. Now, between all of us here, I don't know that the rate really dropped. I just think it made it harder for someone to understand and for someone to examine.
So it was still happening.
Oh, yeah.
Yeah. Okay. So, so that was back in 1975 when they started putting it behind the muscle. And that's kind of the practice today, right?
Has been in the United States the whole time.
No, go ahead.
I was just going to ask, how much more prevalent from then? Because I didn't know anything about breast implants. I mean, then again, I married a butt guy, so I'm good. But,
yeah, exactly. I am the guy. Let's be
one of my best friends got implants. Like, remember? And she'll remain nameless, so I don't embarrass her. Mm-hmm. But we were visiting, and we left there. He's not even a boob guy, so I would have even expected him to notice. But he said, "Holy moly, did you see?" And I said,
"Okay,
I missed that.
I can't believe you did. That was like missing an elephant walking through the room. I mean,
okay, well,
are you kidding me?
I still
go like, how did she not notice that? I mean, boom.
It just shows when I speak to people, I'm looking in their eyes. I'm not checking their bodies out. Anyway, but and that was in the 90s. And I think that was like early. Like, when did this increase, and how much of an uptick has there been in women getting breast implants over the years, recent years?
Yeah, in that article that Dr. Pompa showed me, that society they're international. So they're probably best in terms of getting survey data, and it was 2.2 million annually who get implants around the world. That's just the reporting. You would have to imagine it's much higher than that, because the response rate may be 30-ish% at best to a survey.
Okay. But it has gone up dramatically last 5 years.
And the re-release of silicone into the market in 2006, and then a new vendor in the United States in 2013, and the recent release of another device in the last couple of years. So it's not going anywhere. And, people are on me all the time about like, I had some lady write a review and say I should be lobbying Congress to get rid of implants. And I'm like,
that's not realistic.
So she just give me a 1-star Google review. I don't know who this is. I was like, okay, well, first of all any of us ever want is for patients to have the most information to make the best informed decision.
Right.
Like, I'm not going to make implants, hip, knee, breast, dental go away.
No.
And that's not my job. So that each patient has the most information so they make their own decisions. Most patients don't know that you can have a breast enhancement with their own fat. Going back to the transplant of a identical
we're going
twins
to talk
kidney,
about that too.
but that's why it works, right? It's genetically identical. And then there's all this controversy between butts and boobs, right? So the Brazilian butt lift, which is a fat transfer of the butt, is fine, but magically, if we're talking about the breast, it's not.
Wait, so the butt lift, you're putting fat in the butt. My
Does that hurt? I know.
Okay, so
of course it is.
Yeah, so I mean, okay, now she pins me as a butt guy, and now I'm asking questions about the Brazilian. See, that didn't go over well at all.
I'm not. We're good. Like so, I keep going there. We're good.
Yeah. So
when we go up above the neck, we'll start chatting about me.
Okay,
we're gonna get
because we're gonna tell you
covered.
We're gonna tell you the non-invasive face stuff because Marilyn and I are very natural. But okay, so the butt lift.
Wait, sometimes we see them and we go, that isn't.
I'm naive here. I don't even know what it is.
Fat is the original filler. Fat is the original filler.
Okay.
Which
so
is
first
safe.
of all, what is a Brazilian butt lift? I'm not kidding. I don't know.
Yes, you
it's
do.
adding
we
butt.
see them and
so we're adding fat.
No, but what is it?
To the
I thought there was silicone. No.
Oh, so you can do it with silicone implants just like you can do with a breast implant. But the alternative, and I was doing a series of shows to explain this. Like, there's been biomaterials, it started with like paraffin and industrial grade silicone being injected into boobs. And then it changed to Ivalon sponges, which is a polyvinyl alcohol sponge. That was
just injected?
Straight
it
injected.
Must mobilize then.
Wow.
Forms granulomatous problems, of course. So that was actually started right at the end of World War II to make Japanese women more attractive to American soldiers.
Wow. This guy's a wealth of knowledge.
Did it work?
History.
I guess relative, yeah.
So it didn't fall out of favor in Asia for a long period of time.
So then Americans like boobs is what you're saying.
Yeah. And that's our marketplace, basically.
Okay.
So the butt part started in South America. So that's like, 30 years ago in South America, and then it's filtered up into our, consciousness, via think of Miami. And when I was in leadership, there were a bunch of people who had died in Dade County and LA County. And a reporter figured it out that it was coming from butt lifts. What? So I had to write a safety paper. Y'all can look up.
Like a bacteria transfer? What was it?
No, they were doing the procedure incorrectly.
Oh.
They were taking a long, thin, flexible injection cannula that we used to use for faces, and we're injecting fat into buttocks and piercing the vessels. So the great vessels that run down beneath the buttock were getting injected, and it was just they were technical errors. As soon as you educated on how to do it safely, it stopped, basically. And then, so I wrote a safety paper about that. But I mean, fat transfers have been around for over 100 years.
Well,
they're totally fine.
Isn't the problem with the fat transfer because it would seem logical to put your own tissue somewhere and enhance it? Okay. I mean, that would be like, why would anybody put silicone in something that could
Nice catch.
something that your body's going to attack,
Right.
Low grade autoimmune, blah, 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 right? Everything we're talking about here. But isn't one of the problems though that your body eats the fat?
Nope.
No?
Nope.
It doesn't get rid of it?
Toxicity issue.
Your own fat.
So fat stores toxins.
Oh, yeah.
right?
Right.
So I've spent and probably have more toxicity reports on patients getting explants and fat transfers, explants with or without fat transfers, and fat transfers alone than anybody, certainly in this country. And the amount of toxicity burden, environmental toxins, DD, ETPH, DDT, DDA, phthalates, glyphosates, the mycotoxin burden, and oddly enough, not very much in terms of heavy metals outside of people who
heavy metals typically go deeper tissue a lot,
But the only time I've seen it, Lauren Bossack's my patient, and she was, cooking herself in a Finnish sauna.
No, I remember you telling me that.
So I love to piss off all the people who like sauna. So don't sauna with implants.
Yeah.
Because leaching, not melting, is the problem. The people that like to put me up and talk about the sauna stuff say, because I said, Lauren and I joked about melting her implants, and then I got accused of an ethics violation.
Oh my gosh, you know what I just thought about?
Yeah,
and
it's leaching.
It's not, exactly.
I have another friend that will remain nameless, different friend, but she was so into her sauna that she would like literally wrap herself in like plastic. Do you remember me telling you this?
Oh yeah.
Because I like to sweat. They love to sweat. So the big thing is, everybody listening.
Yeah, but she was causing herself more problems.
I'm wondering.
If you do a sauna session and you feel worse, there's this concept of Herxenheimer.
Hello. Back off.
So if that's how you feel afterwards, that would not be the reason to continue doing that. That would be the reason to like, okay,
back off.
Let's not do that.
Right. Yeah.
And then they asked me about IR saunas. I'm like, okay, let's take a step back. So these devices were placed with no studies in women, basically. The animal studies were done, and then they were placed in women. That, the Medical Device Act happens in the 70s. Everything's grandfathered in, goes through. There's problems in the 80s. Connie Chung comes, there's a moratorium in 91, basically.
What did Connie Chung have to do with it?
Well, there were all these women who were sick from ruptured silicone implants. Big class action lawsuit. That's why there's tort reform basically in the United States, is that lawsuit. And you fast forward, and now we're on our, we have 7th generation, 8th generation devices now. And the point being is any device, and I love doing this because my orthopedic colleagues, I was an associate professor of orthopedic surgery as well. They had something called polywear from the poly in the implant. And you would see it on x-ray. And I go what's that? And they're like, that's polywear. Okay, well, your body's reacting to that. You can have heterotopic ossification, which is abnormal bone formation around implants and things. Your body reacts to stuff.
Yeah, biofilms, bone formation, capsules.
Your body's reacting.
Yeah.
Nothing's inert as much as it's
said. If there's something not supposed to be there, the immune system always reacts. It's a matter of what degree. Would you agree with that?
That's what's fascinating. You have a genetic predisposition to X. You get exposed to Y. You live, you eat, you breathe, you wander around, and whatever gets put in you causes a response.
Yeah.
There's no avoiding that.
And it's a matter of if and when your body adapts, if it adapts, right? Meaning it's trying to adapt always. And then the moment it stops adapting, then symptoms begin. And, all of a sudden, 20 years later, you're going, I've got these headaches, not thinking it's the breast.
Yeah. I don't, once again, envy any practitioner trying to figure this out. I get people coming all day, 7 days a week, telling me through DMs and then in interviews how they've went to, all these different providers, got all these different opinions from, you need to be on a immunosuppressant to an antidepressant to a keto diet to whatever, and none of it works. Or if it works, fleetingly, and then they're kind of back to square one. And then many of them, as you probably heard, they'll put on all this weight.
Yeah.
That's your body reacting, right? When you're in a high cortisol state, you're in a high fight or flight state, and your gut's off, and these people's guts are way off. Between their liver and gut, they are just a mess.
Yeah, and weight loss resistance is, typically these toxicity issues, right? It's like people don't know. I mean, all these symptoms. We have so many open loops right now.
Yeah, I want to get back to the capsule. Yeah. My question is, and as you were saying, you remove them and some don't. Is there a higher risk associated? Why wouldn't everyone want to remove the root of the problem.
Yeah, this is where I think there's a little bit too much fear placed on the provider to the patient. They say you're going to injure the lung. Okay, so for everybody listening, it takes a lot of distance to get from the pocket where the implant is into where the lung is. And if you do, you're not hurting the lung. The lung is basically in a balloon. And if you pop the balloon, the lung's in, you just evacuate the air when you're done, and it's fine. Doesn't require hospitalization, doesn't require any kind of extravagant treatment. It's fine. And so I've done several thousand explants, and I have a handful where we've, from scarring or whatever reason, entered that area, but we haven't injured the lung. Mm-hmm. You get the air out. If you need to get an X-ray.
Sounds way worse than it really is.
If you get an X-ray, I even tell them, Dan, to look for the pneumo, and they can't find it. Because if you evacuate the air and close it, there is nothing to do because you're not injuring.
Is it lung. Maybe just that they're lazy? I mean, could it have to do with not wanting to go that extra step?
I don't think you should ever ask a surgeon to do something they're not comfortable with.
I agree with that. But
surgery is a rep sport.
Right.
And if you're not experienced,
right,
don't have the reps in it.
Right.
You should never look someone in the eye and ask them to do something and then they go.
So you find a new surgeon.
Meaning the more they've done, the better.
Right.
Meaning that's
I would look for a new surgeon if that was.
Right. If you talk to someone and they say it's dangerous, okay, well, it's not dangerous.
Right.
I've done many thousand of them.
Right.
Not dangerous. So that's really not a thing. Okay. You either have the skill set or you don't have the skill set.
So there is a skill set to getting the capsule out because oftentimes they don't get the whole capsule out, and then people remain sick because, the immune system is still reacting. I have, talked to women who said they went back in, they got the remainder of the capsule out, life became good again.
So let's talk about this. So we'll wrap all that up together. The reason I take the capsule out is last year we showed that 29% have bacterial contamination. We'll just say 29% are infected.
Wow.
If you were just to unzip the old incision and pull the implant out and leave all the capsule in, that material would still be stuck to inside the body.
Logical to me.
So the signal doesn't go away. You just took out the device.
Right.
That is not serving the patient. So in that third, basically, you're leaving the same problem. You're not doing anything. You haven't answered the question. So we've done complete capsulectomy my entire experience with this because that's what I would do for a cancer patient. So if the patient comes to me and decide they want to explant, that's their prerogative. If they want a capsulectomy, just like they got an implant, it's their prerogative to ask for that. It's not mine to say it's not doable. If I can't do it, then I say I can't do it. I'm not comfortable, but obviously I'm fine with
that. If they're sick, they're sick, right? Why does it matter?
So you already know that's one caveat.
Yep.
Now, two, this has happened, and I recently where somebody told me from this city, Salt Lake, they had a implant removed under local that was ruptured, silicone gel. Now, there is no way that all that biomaterial was ever actually completely removed because microscopically it can't be.
Right.
Because the capsule's still there. So that stuff's stuck in that capsule.
Sure.
So now, going back to our other discussion of now, your body's really clever. It has T cells that can recognize anything. Any particle represents an antigen. An antigen gets shown to your T cells. That causes a response. The longer those things stay there, the more you get the reaction like we discussed. Those genes get expressed.
Yeah.
Now the B cells and the plasma cells are making antibodies to that shit. Even though you took the implant out, you still got the same problem.
Right.
You left something that's acting like a rejected organ in the person, which is the capsule, not the implant.
Right.
It was reacting to everything, but now you have, say you have bacterial biofilm, right? So that's ramping up your immune system. That oxidizes the fatty acid, oleic acid in the breast to something called oxylipin 10-home. That drives symptoms. That's been shown scientifically. And now this other paper we're talking about has shown ramped up RNA expression because those genes are being expressed. Those products are being stimulated. And every time I gave you the ruptured case, but what if the particulate matter is just over time degrading off the surface? Those are creating tiny opportunities to show antigens to your immune system.
Right.
So you're constantly going to respond to it. Now, you know better than I do. Well, you don't know my patient population. Take a guess at how bad they detox normally.
Oh, yeah, no. I mean, it's a disaster, right? It's not just your population. It's everywhere because detox is not done right. Detox is dangerous the way people do it and creates more problems.
But they don't have good pathways, my point. Like
they're blocked up. Their kidneys, their liver, their gut, their lymph. I mean, and then not to mention their cellular pathways are shut down.
So now you just see that's the culmination of like all those things, right? We talked about the original transplant, and now we have papers showing you basically it's just being rejected like a cadaver transplant.
So, okay, I have to put this all here because I know what people are.
Is this the Brazilian butt lift conversation coming?
We're all here. Did I even get there yet?
No.
I still don't know what a Brazilian butt lift is. All this conversation, I still don't know what a Brazilian butt lift is.
Hold on.
Meaning, is it just adding a fat, or could it be silicone, or both, or is it the same?
You would do one or the other.
Okay.
And it would still be a Brazilian. Well, the Brazilian butt lift traditionally is just fat.
Okay. All right. Traditionally,
are we leaving
the
conversation of the implants and the removal?
Not yet. So here's what I want to.
Okay.
Okay. Here we're going to, but we have to leave this. 800-pound gorilla in the room is these implants, are they bad for everybody? I'm going to give you my experience, right? I think that saying that, well, this person, because people out there know many people who have breast implants that don't have symptoms. They're not sick.
Sure.
Okay. And I'm putting quotes around that, right? Because you could say not yet, or you could say they are, but they're not expressing, right? The body's challenged, it's adapting, right? Okay. Until it's not, but I have over my years can say that when you put some foreign things in the body, you're always challenging the immune system. Yeah. Now, whether someone has symptoms yet is the discussion. So with that in mind, how would you answer that question?
I mean, maybe just headaches. Maybe
are they
just
bad for everybody? And the second part of the question is why doesn't everybody have problems?
An implant that is going to be used for reconstructive purpose, which is how my whole career evolved, is still going to get placed. And you have to explain the risk to benefit ratio. And I don't consider it a bad thing, to put a knee back in somebody or a hip back in somebody.
Sometimes it's absolutely necessary.
Or reconstruct someone's breast who's had breast cancer, because psychologically that can help them. Now, what I do have a problem with is a lack of, maybe clarity or information provided to patients, because I don't like there to be multiple camps. When you put something in, there's a risk profile.
Yeah.
The risk profile is it can get infected, it can extrude, it can be, contracted. These are a lot of bad things. Now,
your immune system could not like it.
Now, that's the thing that's the part that's not being explained properly, because they don't have the gestalt. They don't have okay, in this setting, based on Rob's paper or based on this new paper or based on the information coming out, there's a group of patients who are going to have a really reactive immune response to this.
Right.
And we have to monitor patients. I think people, if you just give them a little bit of information so they can make a better decision, they're fine. Implants are not going away. I probably need both my knees replaced. So they're not a fucking chance in hell I get that done.
Yeah.
Because imagine my microbiome.
Yeah.
My skin is you don't want to be on my, no, if I don't have to get it done, no, I'll just deal with some pain. I'm good.
Yeah. Keep putting stem cells in.
Yeah.
That's what you do. Okay. So here's the thing, right? I mean, why not go? Because to your point, there's a risk. It's challenging your immune system. It's whether your immune system is going to deal with it, adapt to it or not. But why not go with fat then? I know you said there's a toxicity issue, as meaning fat cells carry toxins and you could carry and release toxins. But I would still, if it were me getting a Brazilian butt lift, I'm going with fat. I'm not getting a Brazilian butt lift. That was
that's the
rub,
right?
Butt guy.
So I feel one of the big contributions I can make is publishing a genetics paper about explant patients and how limited they are genetically for detox. And then the next most important thing I can do is show toxicity burden in these patients, what they're coming in with, because that is, to me, the difference between a good, a great and an elite type result. Like I can show you people that come in with no toxicity.
How do you measure that?
So we do an environmental toxicity test through Vibrant Wellness currently. They seemingly have the best.
Yeah, I do. And it's still hard. You're still not looking at like deep, heavy metals in the brain. So we'll say it this way safely. We're looking at somebody who is, you know, cleaner than most people.
That is, you know, and I'm a plastic surgeon, obviously, and we'll just say I'm an N of one because I'm sure I'm probably the only person around this country doing this, trying to look for this before you ever operate on someone.
Well, and you talk about a lot of what you're talking about in your book, and this just is out, right?
Yes,
your SHARPE method is your method of recovery, as you're pointing out that a lot of people are just so
it's
toxic.
It's prep and recovery because if you don't identify those things up front, here's why I think there's what you asked me. Like,
here, but because I just said it, where can they get the book?
Yep, you can get it on Amazon, Audible. You can order it from us on our store, and it's on Apple Books as well.
Yeah, and you talk all about breast implant illness in here. Yeah. You talk about what you need to prep with, what you need to do before and after. And I think you make some really good cases in here.
Yeah.
You know,
the patient I'm talking about who had a fat transfer is in there.
Yeah.
And she did something, you know, intentional 15 years ago. She said, I am going to start a family and I don't want to have anything toxic in my home. So she just started doing things back then that, you know, we talk about a lot now. But looking at all the labels of the products or detergents or
hey, this is my Instagram page.
Looking at food back when it wasn't cool, like doing all these things. Mm-hmm. And when I got her tox test back, and it is limited, right? It's not some deep dive into everything, but she had nothing of consequence. And so also she was an incredibly emotionally stable person with a very good supportive spouse and very grounded in her situation. And she wanted to get her explant done. She had a problem with sexual abuse and overcome that in her life and really was disconnected from her body for a long time, but had, you know, through a lot of self-work and other modalities, just reconnected and want to get this done. And so I did it for her. She's very lean, which is, your question is like, who can have this? Well, I get DEXA scans on people. I examine them in person if they're low BMI, low body fat.
Wait, what was my question? Yeah, the fat transfer.
Yeah.
Okay. All right.
So the toxicity is one parameter.
Okay. Too low body fat's another.
Too low body fat. So you got to have a source. And the easiest place to do this is recontouring the waist, the inner outer thighs, kind of hip area. I always kind of remark, I can make anybody like size 6, a size 4, size 4, a size 2, size 2, a size 0 by doing this for them. And then you have to move it into the correct space. So for the breast, because the breast tissue occupies the space above the muscle between the fatty layer and the skin, you don't want to put it in the breast. That'll create cysts and that'll cause problems on any kind of ultrasounds or mammograms or MRIs or anything down the road for any kind of surveillance. So you want to put it in the fatty compartment. So everywhere on the body, there's a fatty compartment beneath the skin, above the muscular layer, or in this instance, above the breast.
When you put that fat there, I mean, does it look uniform? And there must be a limit to how big you can.
He knows all the questions. You know, I apply surgeon.
Well, we know we've seen the train wrecks too, so we're wondering that's over the limit.
Right. So there is it's a capacity equation, right? So you want to put it in a more uniform way. So back in the day, we used to do it by a syringe method, and now we have a very elegant system with a power pump, and it's very uniform and it's very simple for me to do. And you think of it, you're like planting seeds or rows. You don't want to clump it. You want to just glob it in there. And so you also have to understand when the skin stretches and reaches its capacity, it's not then the cue to put more and more in, because it really won't work like that. So the easiest cases are always the patients who are ones who, for instance, have breastfed, went up and down in size. That's easy to do, just like it would be to do a cosmetic augmentation with an implant.
Because the skin is already stretched. Okay, yeah. So you're filling it to that point. I mean, how big can you make them?
Yeah, so I always have the same discussion with patients. If you want to be, simply a cup size bigger, fat transfer all day
Easy.
long. If you want to be more and more, larger in terms of size, then I have a discussion with them of like, are you having problems with body image in terms of what you see? Because the kind of very full, shelfy upper pole, if you're watching this on TV, is not natural. That's made up.
So you direct them to a counselor?
So I won't do things, and I never have done things that I don't align with.
Yeah.
So I've never done that, and I won't do that because that's a whole different problem.
Well, isn't the fat transfer going to give you a more natural look anyway? Yeah.
But the problem is nobody knows what natural is anymore.
Yeah, well, that is the problem.
It's been distorted.
Do you find that when you remove fat from one part of the body and put it into another, will that part that you remove it from, because I'm assuming, especially women, right? Our bodies are designed to hold a fair, I don't want to say a fair amount, but some body fat compared to a man, because for childbearing purposes.
Yeah, and intelligence wants to hold 25%, 30%.
What happens post process? And does the body, do you find that the body wants to restore body fat again?
I think it goes back to what we were talking about. So in the SHARPE method, we try to align everybody's, like, first thing I prioritize is their sleep, and then what they put in their mouth, the fluid, the food, air quality, supplementation quality, like really try to get them to understand those things make a difference. And then looking at, although I don't do this for everybody because I can't anymore, is make sure their hormones are in balance, because as you're premenopausal, menopausal, and postmenopausal, a lot of things are changing. And if they're not being looked after properly, and the Women's Health Initiative study was probably the biggest disaster, or one of the biggest disasters, where it deprived women of hormone replacement therapy because they said they would get breast cancer, which of course it wouldn't. So just making sure they stay in a state of balance, because this works extremely well, as you would imagine, in younger patients. And then you have to really get on point as you go into perimenopause, menopause, and postmenopausal patients, because you do need hormonal balance if you're going to have the fat live. And I used to do this for cancer patients who were on hormone blocking therapy. So those were absolutely the most difficult cases, because they're on a specific medication to block them because they had an estrogen positive cancer. You need a level of estrogen to support the fat,
the tissue.
Yeah.
But did you get your question answered though? In other words, I guess what you're saying is if you take it from one place, are you going to gain fat in another place because your body wants to keep a certain percentage? I think he's saying
if your hormones are able to feed the fat, essentially, right?
So if you get out of balance, you can eat your way out of a result. So if I take it from one place, it's not going to magically go somewhere else.
No,
it's
the
the Swiss
go
cheese
else.
effect.
The body says, I want 30%.
Oh, yeah.
So therefore, you know what? Now you get a little bit more in the butt if you took it from the gut.
Or does it go back to the butt or the gut?
That has not been borne out study-wise. Yeah. In the simplest terms, there's ways I look at that objectively, like weight, DEXA, and then following patients. But just, is somebody going to have it done and then, go throughout life and it's going to change and go back to where I took it from? That's more, to me, more of a lifestyle thing versus, is the body really just pissed because I took some fat and they want to fill it back up? Mm-hmm. I mean, people genetically will get bigger hips.
Well, I mean, tell me if I'm wrong. Rarely once you're an adult, you gain fat cells. Your fat cells just become more expanded. So if you're taking fat cells from the love handle, putting it in the breast, there's not cells there anymore. So
there are. You're not taking.
I made a mistake in what I was saying. I mean, meaning that those cells are gone. You're taking those cells. There's other fat cells. You're not taking all of them. But my point is that if you got fat there again, you're not adding fat cells. You're expanding what's there.
More hypertrophy.
Yeah, exactly. Yeah, or you're expanding cells somewhere else.
That's even a little bit more nuanced, because the best cells to do fat transfer come from a specific area because they have a better stem cell fraction. Because the adipocytes have their own stem cells, the MSCs.
Yeah, of course. Yeah.
That's the sauce, basically. And we don't talk about that enough and that's like a way deep dive in this, but the fat to me is a really underutilized tool for stem cell, therapy because of our country and its kind of position on stem cell therapy. It's a little challenging, but I've worked with adipose-derived stem cells, stromal vascular fraction, since the early 2000s. And I think overall, and I'll go back to a younger patient. So if I did this on a young person and their skin contracts down, everything kind of scars down, and they maintain a really healthy lifestyle and they're taking care of themselves, it's totally as you would expect. It makes you look like a magical plastic surgeon.
So removing fat from the areas people don't like and putting it in other areas, even in the face, which we're getting to, that sounds like a positive thing. I mean, again, from my aspect, I don't like foreign things in the body. I think I would, unless you have to. We both made the argument there's a time and a place for anything, right? But if you can go with the fat, go with it. That's why I wanted you to lay out who's this for, what is the potentials here, right?
I think, the way I look at trying to raise awareness for everybody that make it easier for you and I in terms of dealing with folks who have too much toxicity or too much inflammation is using this as a natural alternative.
Yeah, I think this is a great alternative.
Provided you work them up beforehand. And I will have to get more advice from you about like some of these more complex toxic burdens to look at, because I every time I see a laundry list of stuff, I just try to figure out, are you from Florida or did you grow up around ag? Or where'd you work? Did you live in a moldy basement? Like what's your MO? Did you travel to Cabo and go off property and get a parasite, or Costa Rica, or you went on a mission trip somewhere in Africa? I mean, this is the stuff that people don't know.
Oh yeah. Well, what people don't know is what starts your toxic burden is it happens in utero. The number of silver amalgam fillings in mother's mouth is proportional how much ends up in the baby's brain.
I looked up that study too.
Drash study. Yeah. I mean, lead, everything, okay, Mary, I mean, so you sitting there as a woman, right? I mean, we have women who are putting fillers in their face, which I've done videos on. It does mobilize, even hyaluronic acid stays there. They're finding on MRIs going, you have a tumor. It's not a tumor. It was, mobilizing hyaluronic acid. Again, the immune system hates it. I hate it. So we're talking about, you could enhance your breasts, you could enhance your butt or your face and do it naturally. I'm looking at it as a better solution. Why aren't more people talking about this? And would you consider it? Because here's a girl that never does Botox or anything unnatural. I don't know.
When you're going to use fats, and there was a study done by Dr. Val Lampros, and he showed over time what happens when you augment somebody's face with fat. So pretty much the take is what you hear. Like you're asking, does the body eat it up? Well, everything works in the face. Richest blood supply, best lymphatic drainage. If you put fat in the face, it's going to heal and it's going to be there. And
solution.
If you put it in the wrong place on the face, it's going to be visible and palpable.
Mm-hmm. Okay, so there's the risk.
Yeah. So
you got to go to the right guy.
It's always got to be everything's operator dependent, number one. And then it's always be more conservative on a face, because that is something that you can't walk back.
Yeah. Okay.
Yeah. Okay.
So it's going to work. And, if you remember the folks who
come here
got treated with protease inhibitors had atrophy of their midface. That was the HIV treatment that really helped save patients. And then they came up with Sculptra, which is a filler. It's basically like liquid Vicryl. Vicryl is an absorbable suture material. And this stuff was very thick. And my research in medical school was on HIV. And when we were getting this product introduced to us, they wanted us to help patients who'd basically been stigmatized from taking this medication, the protease inhibitor, because their midface just would go away. It's kind of like Ozempic face.
Oh my God. I was just going to I did a video using your video on Instagram. I said, Dr. Rob Whitfield, expert, board certified plastic surgeon, is talking about Ozempic face. And you know what women are doing? Putting filler in for Ozempic face. Oh, and then if you flip them around, they don't have a Brazilian butt. They have Ozempic butt. I hate Ozempic.
They might be calling you for the butt lift.
I hate GLP-1s.
Oh, you don't do those anymore,
YouTube
you said, right?
censored my video and took it down.
Oh, really?
Oh, they didn't take mine down.
Is that a pharma thing?
Well, they're like, anyway. Yeah. But it's just like, it's very cyclical, right? So
so mine must have been affected. Oh, anyway.
Probably. Hey, sweetie. So none of this stuff is new, right?
Yeah,
so
right.
If you're going to take a GLP-1 and the new ones coming are going to be much more effective than the ones they have currently.
What does that mean?
So they'll whack just fat, not muscle, at a higher rate.
And what's the consequence?
So the thing that you don't want to do,
yeah, of course,
is ruin your facial fat. And that's why Ozempic face is such a problem. Personally, I'm on the back half of my career. If I was a young plastic surgeon, I would be thinking of how can I help somebody in their 30s, 40s, 50s who's taking GLP-1s and really burning their facial fat, because eventually they're going to come in because you're causing premature aging of your face.
It looks horrible.
Because if you take the structure of your face, and we used to always have guidance in our clinics by our mentors, and they said, if you're planning to lose 5 to 10 pounds, your facial aesthetics will change.
Mm-hmm.
Mm-hmm.
And that's a huge problem. Because all of these drugs work. You know this.
They work in the short term, but long term, people are stuck on them.
And now the consequence of that is maybe you've lost your weight. We'll say you're on your maintenance dose. You're doing fine. But now you look like shit.
Mm-hmm.
And now you're coming to my office.
You look skinny, older, and without a butt.
And now your face is deflated.
Mm-hmm.
And I recently had this happen to me. And there was somebody who was upset about their face. And I was like, well, and if you look at your face straight on, you don't really see what's wrong with your face. If you turn it at an angle and somebody takes a high-res image like this, like you're looking at a corner, side to side, and compares before and after, if you have them, like, hey, it's a good public service announcement. If you're going to do a GLP-1, get your facial photos done at all angles before you do it. Because I fortunately had these photos to show this patient to help them better understand what they had done to themselves. Because they were very attractive, and they still are very attractive, but they lost mid-face fat.
Wow. That's the worst.
Yes. Yeah. And I told them, I'm like, now I can do a lot of things, but I am not Harry Potter. Like, this is a problem. And they're like, well, can you put filler in me? I'm like, I don't put filler in people. That's not what I do. And they're like, well, you put facial fat in me, because I said, to me, this is a fat grafting issue now. And I said, you know what I do 100% of the time now is I take care of women's breasts, and I do breast augmentation with fat. I don't do faces anymore. Back to the rep thing. If you don't do it, I don't think you should dabble. So I don't dabble in these things. So I do 3 things. I do explants, I do augmentations with fat, and I do a no-cut facelift. But I don't do facial fat
talk about that
anymore. So, but this is what these people are going to need. So if I'm the younger version of me, I'm like, I should be getting my fat grafting.
I mean, honestly,
faces.
You need to be marketing. I'm giving you business advice, but you need to be marketing this Ozempic face solution, because fat done right is the only answer that I can even see.
But he's not doing
now.
the transfers.
The fat.
No, not in the face.
Yeah. I'd say this is the solution to the problem. I will, and I've always tried to be like very straightforward about this, because your face, you can have a breast procedure and kind of be covered up and wander around. Face is very different. I mean, you're down and out, and if someone's just doing faces, then I would encourage them like to have these conversations, because this is your like plastic surgeon who's just doing face, or this is your ENT facial plastic surgeon who's just doing face. Like, they really gotta, like, I have taken shit for breasts. They have to like get up and start like talking about this more and kind of guiding people and being more direct about what steps to take. Because if you don't give better guidance, you're going to have a lot of problems. Like there's just no walking back somebody who loses 50 pounds on facial aesthetics. Their neck's going to get loose.
It looks horrible.
Their jowls are going to look terrible. And now we're doing this. There's like kids on this now.
It's crazy.
Teenagers.
It's nuts.
It's crazy.
So, okay. So, I mean, but you do put fat in the face.
I've stopped.
Oh, okay. I
yeah.
thought you were
So what I do for faces, and we'll talk about the no cut like we've talked briefly about. So the no cut for me is
okay. Hold on, back up.
Yeah.
So we talked about breast,
yep.
Augmentation. You still do the fat in the breast
Yes.
augmentation. Yeah. Okay. You stopped in the face. Why did you stop in the face?
Because I stopped doing open facelifting.
Okay. All right. Fair enough. But why?
I don't like scars.
Okay. All right.
Yeah.
So you do no facelifts. That's
I
why
don't do any
you
open
moved to this
facelifts
non-cut facelift
Yeah.
because of the scars. But people don't care because they put it back here.
Oh my gosh.
I'm just saying. This
when you
is
look
what I
at
hear.
people the way I do, everybody's flaws.
Yeah. Someone like you,
Yeah.
I can tell who has had facelifts and not. But I mean, you can tell a mile away. You don't like the look. I don't either.
No. Any visible scarring really bothers me. That's why I don't do tummy tucks anymore.
He's a perfectionist. What do you expect?
I mean, that scar is hideous. And I spend a lot of time trying to help women overcome breast scarring. So I have this mantra. If you put a scar on somebody, it better be damn well worth it to the patient. Like you better be able to deliver something for that. That's a big, problem.
Wow.
Long term.
Mm-hmm.
So you can't pick your parents. You can't outrun a bad diet. You can't get away from a shitty scar. And if you put one on someone's face, you got to get it to heal properly. They've got to take care of it, and all this garbage with Kim Kardashian. And I mean, they are photoshopping the shit out of her face all the time. Every time I see her, it's like a different version of somebody's face. I'm like, who am I actually looking at? Because eventually, when you wipe all that stuff off someone's face, you're going to see all these scars because you don't get a change without a scar.
I will say her mom looks very good after her facelift.
Yeah. I'm sorry, not Kim. It's her mom.
Judge facelift. Right. It's her mom.
Yes. Yeah. I'm talking about her mom, not her.
Yeah.
But just in general, like this,
okay.
These folks have driven this conversation.
But you're seeing the done up versions.
Well,
does she look good? I don't know. Maybe Rob.
Right. She was in the swollen phase for several months, which is what I was getting at. Like when you do somebody's face, whether it's there's a superficial facelift, there's a more platismal or deeper tightening facelift, and there's one called a deep plane where they're doing more deep work. I mean, all those come with different levels of swelling and down.
What about like the lymph, moving, like how is the lymph affected in a facelift?
It's always affected.
Right.
Yeah. Anytime you're doing a face and neck, that's why people just don't get it. Like there's a lot of effort put into facelifting, and just like I don't dabble in that anymore because I just don't do enough. I stopped doing noses, I stopped doing faces, and I do thousands of breast cases. I mean, like you can ask me some specific nuanced thing about a breast, I could probably give you a whole bloody dissertation about it because it's all I do.
You do the breast explants correctly, and then you help modify it post. That's your expertise.
All these derivations of them.
Yeah.
Like those cases are complex, and every once in a while I'll get somebody famous will DM me about, they want to do an explant, but they're not ready. And I'm like, well, send me a picture and then I'll try to come up with a plan. Because the problem solving part is very interested. And that's why we switched from open facelifting to doing the no cut. Because I don't like the visible scarring. You can't hide it.
Mm-hmm.
Even the best scar that ends up behind the ear, you'll have some kind of wrinkling of skin sometimes because there's not a good way to hide it. And it's especially bad on males. The kind of longevity of them too has been overrated. Like facelifts don't last forever.
No.
That's ridiculous.
The more you do it, then the more horrible it looks because you're stretching and stretching and stretching, so the skin gets thinner and thinner and thinner.
You can only do the deep part one time.
Yeah,
basically. And then it's just skin.
Do they ever have to remove, I'm just curious, lymph glands or anything to accomplish a result?
Do that. Sometimes they'll do subendometrial gland removal. I think that's what you mean.
Yes, correct.
I was never an advocate for that. I think all that's
I mean, that would be,
I
I would think that's dangerous. I mean, you need those glands to drain.
Yeah. Anytime you start over manipulating stuff,
totally,
you're going to buy
Someone was talking about that.
You're going to buy something that you don't want. Like I'm very I was trained by excellent general surgeons, vascular surgeons, cardiac folks, plastic surgeons. I have tremendous mentors. Some just phenomenal people, and they taught me a ton about, like you brought up hernia mesh. I had a mentor who absolutely despised hernia mesh.
No, I
that's amazing. That's great.
And he taught us how to manage it. And then I had plastic surgeons who, taught me how to do whatever case, the micro case, the facelift case, the breast aug case, the lipo case. And you have all these people. And then if you get old enough and you operate long enough, you try to look for ways to help patients that make the most sense. So I stopped open facelifting because everybody's heard of microneedling. So microneedling is like aerating the lawn. It just pokes holes. And because your body's immune system works, all your machinery makes new collagen and it looks better. Now, it doesn't give you this, wow, visible change. That's not what it's for. So microcoring, and the company's Elicor, they took and made hollowed out microneedles. So now they can extract skin, kind of like when you do a hair transplant. You move a little hair follicle from the back, move it to the front. Same type of thought process.
This is the non-surgical process that you do.
So now you're taking that tissue out like a little tissue biopsy. So you can take out a square inch of skin on someone's face the way we do it. So we do the whole face. And then, we have different.
So what happens? You get a natural tightening.
Yeah. So it can't look pulled. Like when people do this is not natural.
Have you had it done?
No. Okay. I did it for my wife. I don't get to do anything. Yeah, I think, that's a great question. So you're always going to continue to age.
Different for everyone, I'm sure.
And then your skin laxity is the issue, or skin damage. Like if you grew up on the coast of Florida or California or Texas, you're going to have more sun exposure, more skin damage that way. Or if you had somebody who just naturally aged faster, the folks who seem like they age the least are Asian. Like they have such elasticity in their skin that's great. So if you, and I don't show before and afters of Asian skin because of that. It's just not realistic. So you take the skin out, and that's the superficial treatment. So instead of microneedling, you do that. And then we have a tightening treatment that we do for the cheek and jawline and neckline. And that's done with FaceTite. So that's bipolar radiofrequency. So think of like a very sophisticated set of tweezers. And one part of the tweezer goes under the cheek skin and one stays above. And it's so fancy that it doesn't hurt the skin.
It's like ironing it.
Yes, like a curling iron. Like it shrinks and tightens it using heat and radiofrequency, but it doesn't injure the skin. And then finally, you have to do something.
That makes more sense than just trying to get it from the top. If you're going underneath it and from the top, you're getting all of the dermal layers.
You go like from this angle.
Yeah, that makes sense.
And then here is easy. So you're trying to be very strategic. And then the neck, there's a minimally invasive neck lift I do that I can do literally in like an hour under local. And it helps divide the little bands that we see here. And that helps just tighten it. So everything I do always has to be, one, it has to look natural. I have to be able to do it under local for you. I don't want you to have to go sleep if you don't have to for the faces. And then finally, if we have the ability to have taken your fat out and sent it to the stem cell bank to process to have your stem cells, I always want to apply your own genetic material in the form of stem cells back if I can. And then like you've talked to me about exosomes or other options. The pyramid to me always starts at the top with your own tissue.
Yeah.
And your own stem cells, and everything else is running a very distant second, third,
even as you age,
fourth.
Is that still the way it would work?
Aging stem cells are not going to be the best,
right?
But this is where I'm still a purist about my own stem cells. Yeah. And I don't give them back IV because first pass in your lung, you'll filter a bunch out. And
yeah, I mean, one of the things we do an expanded stem cell. And yeah, I mean, they go to the lungs first and they stop there. But, you know, stem cells are only releasing healing factors anyway, meaning like those factors get released because they were like, well, how does it even work when most of them are stopped in the lungs? When they stop in the lungs, they're releasing the factors. And really, that's all stem cells do. People still think stem cells are going to damaged areas and then creating healing. Not really. It's the factors that drive your stem cells to the area. So it's still your cells.
That's why I like direct site, either injections or I had my own stem cells done for my neck because I have a bad neck.
Direct site when you have injuries.
Yeah.
That's how I got
So that's
fixed,
how I like to do it, either direct inject, aerosolized, but that's always my preference. So the combo is do the minimally invasive neck lift, do the skin tightening, do the if you will, removal of skin without scarring. Because there's no scarring from that.
That's brilliant. So you're just removing little areas. And how, what's the recovery like? I mean, obviously.
Yeah, so the first week you look like shit.
Yeah.
Yeah.
But usually it's a lot
if you're going
longer
to get
for
a
a
facelift
facelift.
or this done, you're going to look like hell for a week. So don't, like the facial stuff, nobody should dress it up any other way than it actually is. It's going to leave you looking banged and bruised. And if it doesn't, then I would be very resistant to go get it done.
You should, like she does microneedling with exosomes.
Yeah.
And she's never done anything to her face.
Yeah.
There's no Botox on that face, obviously no surgery and no fillers, nothing, right? So going the natural way, we have said to you, when I heard you did this procedure, she would do that, right? So which you're going to get it done. But yeah, I think
the question is when.
Doing it with
The question is
exosomes,
when.
I think would be the way to go. Because here, the thing about exosomes is you can take someone, severe burns, like, that case, they said it would take 6 months to heal this, right? Literally in 1 week, the person was like, no pain. It's like,
well, and I told her too, when we do them, I have people, of course, in my client base who want to use very specific products, which is absolutely fine with me.
Yeah. You don't care post-surgery. Not surgery.
Those applications are important in terms of healing, especially if they've already used them and have had really good experience. Like everybody's their own end of one. Like I can tell you what I know pragmatically works the best and what I've seen.
I do exosomes. Lately, I've been doing it more regularly.
Yeah.
And if I do them at home, obviously I barely see anything from the needle that's used, right?
Yeah.
But like I was just in Cabo, they have a new tool that they're using and it like stamps it. And actually though, completely painless. And I walked out I wasn't even red. And my girlfriend that was actually back at my place was like, what'd you get done? I can't see anything. And that was the idea. But I've done it also with a different level of microneedling at one of his other locations before he got this. And I've walked out feeling sunburnt. Right. And red. But the next day it's completely gone.
The idea of the microneedling is more like traumatize it, get it to heal better, right? This is actually taking skin out and creating a contraction.
My thought about this was always like, this will help change how skin ages. Because if you can remove it, say continuously, in a loop, like if the cycle is, hey, sweetie, here, you're going to knock stuff down. If the cycle of aging starts, when collagen is going down, so you don't see this happening, right? It's happening.
Oh, yeah.
Just imagine, from the age of 30, getting done every 5 years.
Okay.
So by the time
well past that,
you go, 4 cycles, you've taken 4 inches of skin out of someone's face. The way I'm talking about. That's far more than you'd ever take out of anybody on a facelift. And you would have no visible scarring.
Yeah. And because a lot of it is driving the healing throughout, it won't be that stretched look. Because a lot of it, your body's regenerating.
It can't be.
Yeah, that's why I'm thinking combining it with, a stem cell or an exosome or, you could even technically use PRP, spin their own blood down because there's growth factors in there. right? It's like, and you're driving even more of the healing.
And for all those folks who are flipping out right now, listen to me talk about doing this under local. Come 26, we'll have our surgery center open in Austin where I'm practicing, and we'll do it there with our anesthesia team. They'll give you a little sedation.
Yeah. And where do people find you? I haven't even said that.
Yeah, I'm in Austin, Texas, and we would love to have y'all visit again. We had a lovely dinner there last time. But
yeah, it was the health food. So what was the name of that place?
That when you go to Austin, you eat at The Well.
It was amazing.
And they're gluten-free, dairy-free, no seed oils.
And very nice.
Yeah, and very good food. But how do they contact you? Did you say that? Your website?
Yeah, I want everybody, if you want to learn about the no-cut or explant or fat transfer, go to drrobertwhitfield.com. Fill out a contact form with what you're interested in. We have our books and supplements and SHARPE programming, but that is where we've put and consolidate all of my 8,000 videos and 140 podcasts.
Well, I'll tell you, my takeaway from this conversation is you can't mess around with who you let mess around with you. I mean, seriously.
Isn't it true?
Like, I'm serious. I mean,
that was kind of one of my takeaways too.
I mean, I don't think I would go to anyone else for any of those 3 procedures.
Well, isn't it funny? I mean, you really know this is what I do, these 3 things. Like, I like that because I agree with you. Too many people dabble. Too many people are experimenting, and it's like, it is not on me. No way.
When your level of knowledge and obviously what you know reminds me very much of how my husband operates. If he doesn't know something with such ferocious clarity, he's not going to discuss it in a way that promotes it, I should say.
I can't. I don't.
Yeah, it's called integrity.
I experiment on my wife first, and we go from there.
Yeah, I think we probably get both frustrated by others doing things.
Of course, but that's okay.
Well, there's so much in this conversation right now. Like I said, we did somehow manage to close a lot of the loops. I'm going to go back to the Brazilian butt lift one more time. So, no, not really. I think I do understand what it is. There's some key numbers on
the butt lift. If anybody puts less than a half a liter of fat in, you're not going to see a visible change in the butt. And when it's a breast, low BMI patients, I'm trying to always get as much as I can for them because it makes the biggest difference when you're low BMI like that. That's why they got an augmentation. They have many, many issues with their body and their image. And it's very important to understand that safe explant and fat transfers can be done in low BMI patients given the right set of circumstances. So in our book, we talk about it, and I wrote and published the SHARPE Method not to hide it, but to make it available so everybody can understand how we think about it to get the best results.
Yeah. Yeah, no, I mean, I think when I always thought of a Brazilian butt lift, I was thinking these you see these women at the gym and you're like, what is that for real?
And there is one that is, and he refuses to accept it.
I'm like, no, that's
I'm like, but I know this for sure. Not because no.
Yeah,
that's because a guy I know told me it was, and I trust him because he would know.
Yeah. And my wife does not need a butt lift because now everyone's like, oh my gosh, he wants his wife to get a butt lift.
Not he does
true.
Not.
It's her butt.
But he does comment on the butt. That is a thing for you. Always has been.
Yeah. Okay. All right.
I mean, I'm not.
So I'm a butt guy.
You're a guy.
I'm not a boob
that's
guy.
nothing for you.
You're lucky I'm not a boob guy.
Right. That's what I said. I'm good.
You'd be pumping fat into those buggers.
I don't know that I would do that.
So what's do people, if they go to your website, do you see before and afters and all this stuff?
Yeah. So what we've done now is
it's all Asian women though.
All of a sudden I wish I was Asian.
We've actually made our landing page, my AI clone, to ask me a question about any of those topics. And then my preference is always, this is a very long journey for most patients to get to me and then get to the point where they want to do something about that. So there's many, many videos that they can just go through and kind of binge on, like, Netflix or listen to podcasts. And
tell them where your podcast is.
Yeah. So it's perfect because this won't be out for a while. Mm-hmm. So it's going to be called The Surgeon's Lounge. And it's both on Spotify and Apple and all the standard podcasting platforms, as well as it'll be on YouTube. and on Spotify on video as well.
I'm going to come back and hang out in the surgeon's lounge again.
Well, you might have to.
Actually, you know what we'll do? We'll do it post your thing.
Yeah.
We'll do it.
Or you could bring it in the operating room.
Well, the new surgery center has the podcasting studio.
I think we could wait for that. That gives me a little.
What's that? I'm sorry?
The new surgery center has the podcasting studio.
Oh, that's cool.
Oh, how much time do I have until I anticipate when I will see you when that opens?
It's going to open early 26.
Okay. If you give me just nitrous, I'm good.
So
that's what they all say.
I'm kidding.
To cap this off, who would you say, you have women out there that are considering perhaps, getting their breast implants out. Yeah. Okay. I find that that's a very emotional thing. I find it is, especially as a man, I don't go there. Like, even if I have this absolute sense that is their reason why they're still sick and tried everything and nothing's working, right? Because that's typically what happens. I'm very sensitive there because it's an identity thing. There's an emotional thing, right? I've learned that husbands are a factor there with that, right? And we've even had friends, with that scenario. It's the husband why they say, they still have them or they don't want to get them out. So there's a lot of stuff there, right? So it's a process that women go through of years before they finally say enough is enough. When would you say, okay, you need to really consider this? I mean, I don't even know what I'm asking.
When they're sick enough.
So here's, I understand exactly what you're saying. So I try to frame the discussion this way. Where my clinic is in Austin, Texas, is literally like climbing Everest. Everybody else is either never going to get there, they're never going to get on the plane, plane, train, automobile. They're never going to get there. So for everybody else, we really wrote the books. SHARPE is there to support patients. The only way I used to be able to get SHARPE was to be my patient. But we wrote a book about it and we started a group to help the patients. So there's more support. So the team that runs my group, I explanted. So the women in the programming are explant patients of ours.
That's smart.
So that's much better. They can relate to and understand the issues and can support the patients. And you can always, as you know, help lower someone's inflammation by taking certain steps. Sure. And in the implant illness population that we deal with, because we understand their genetics so well and their toxicity burdens, gut problems, and certainly some of their hormonal problems, it becomes a little bit simpler for our team to help them because that's all we do. I don't do anything else. So that's what we see all the time. And people ask, can they use SHARPE and not explant? I don't have enough of a sample to tell you how well that will work, but you can run it and kind of get yourself to a point where
for me, it's like, can I do your detox, Dr. Pompa, and I'm still going to be in my moldy home? That's an example. And I'm like, well, I hedge it because it's like, well, it might help, but that input may be too much and until it doesn't, right? So that's a hard question to answer. Yeah. I
try to give everybody, like, to your point, a lot of grace, right? I let everybody know when you come see me, I have never, ever, ever, ever told a patient they should explant. That's not my decision. They come to me.
Well, by the time they come to you, they've made the decision.
That's what they want to
do.
Right? When you enter into my ecosystem, you've spent the 1, 2, 3, 4 years trying to figure it out.
Yeah.
And you decided, well, this would be the step I need to take. I don't need to tell you to do that. I need to explain to you what's the best plan. How can I guide that person in the process that is very, to your point, difficult one. And, I love it when they've done more self-work and their spouse is on board and they have really kind of gained some momentum that way because it's challenging if it's not.
I'm in a little harder place than you because I'm more on the front end going, they're coming saying, hey, I want my life back, right? It's like, and then I'm looking at what's going on and this oftentimes is a glaring problem. And and to approach that can be very difficult. So once they come to you, they've already approached it.
Yeah.
So
we may have to start doing more primer videos, you and I.
Yeah, I think you're right. Well, wealth of knowledge. I mean, you're going to want to like and share this because people need to know this information. There's alternatives here. And that's what I hope people got out of this. her and I got out of is like, you don't want to just go to anybody with a lot of this stuff, right? And I hope you got the fact that you don't want to put foreign things in your body unless you have to. Choosing to do it, there's risks there. So
and the confidence that you have is obviously from the success that you have and where you started, right? As a microsurgeon.
Yeah, microsurgeon. If I want someone to
absolutely. I mean,
it better be him.
Oh, absolutely.
Yeah. All right. Well, great information. Thank you for being here. Like and share. Always the information's needed. Dr. Papa Podcast. Stay tuned for the next incredible show.